Okay, so this is a patient with history of like I think abdominal pain. Let me see if I can. Anyways, so then they got GI got a this is benign. GI got an enterography to see if there's a bowel source for pain. And so this is what the MR enterography showed.
So that's a gorgeous enterography. Do you guys give glucagon?
Yes.
Yeah, like not a lot of bowel peristalsis.
Oh, sorry, I have more history. History. So abdominal pain, has a history of UC, ulcerative colitis, rectal ulcers, had abdominal pain, bloody bowel movement, and weight loss. And they're trying to see if there's like a superimposed Crohn's on top of, prior diagnosis of UC.
And that really thick loop on the top, is that?
Yeah. What is that? What's that? No prior CT. I mean, sorry, we do have a prior CT and it wasn't there. But that was like a remote prior, like over 7 years ago.
I don't know. I'm concerned about lymphoma, given how thick it is.
Yes. Okay. Any other differential that you would add to this? Yeah. So
less likely Crohn's.
Likely Crohn's. Okay.
No,
yeah.
less likely Crohn's.
Oh, less likely Crohn's. Yeah. So I was, and I'll give you the diffusion, which, where's my diffusion? Here's my diffusion. So that bowel segment is right here.
It's not restricting that much. So that's not, it goes a little bit against my,
no, it's right here. Yeah, right here. Sorry. Does that, I can see if that works out.
It just didn't look that dark on the ADC.
Yeah. Yeah. So let me pull it from side to side. There you go. There. Does that help? Yeah, here it is. Okay. So they did a double balloon, like they went in per oral, and then they did, I think they called it a double balloon enteroscope, and because it was kind of deep, and it was negative. There is nothing in this area of concern.
Is it just like it was like transient enteritis?
So then we gave another differential, intussusception. So then she got a CT subsequently, and now it's all gone. So that was transient intussusception. Wasn't that?
Wow.
Yeah, right. Yeah, exactly. And in retrospect, you can kind of see you kind of make that out, right? Maybe. I mean, it's a hard diagnosis to me personally, but you can see that right here a little bit. Like you can see that telescope appearance right here, maybe here. So this is the case of apparent bowel wall thickening, lymphoma, other abnormalities, but turned out to be intussusception.
It's interesting too, because usually we think like the transient intussusception in adults is usually shorter segment.
Yeah.
So yeah, that was unusual.
That's a great thought. Yeah. So that was my case. I have another one, but I want to pull it up.
So just a quick question there. So is the history of ulcerative colitis or Crohn's predisposed to intussusception more?
Oh, good question. I don't know. Aarti?
I don't know. I mean, I know that basically any kind of edema or hypertrophy of the lymphatic patches in the submucosa can lead to, that's why in children it's more common because of their lymphoid tissue. So I would assume if you have inflammatory segments in Crohn's, you could more easily get intussusceptions. But from my personal experience, I haven't seen that a lot. So, and it sounds like Nelly, they didn't see anything. Like, not only was there not a mass, but it wasn't like it was even inflamed, or they thought there was like Crohn's disease there. So
that's correct. Yeah, there was no erythema. Yeah. Mm-hmm.
So purely incidental in this case. Okay, gotcha. Thank you.
Yep. Amar, do you want to go?
Sure. Do you guys see the case?
Yes.
So this patient, I will go over the images. Unfortunately, I don't have coronals or sagittals. I'll withhold the history. The history would be a giveaway. I'll let you guys see and see what are your thoughts. So the current history, the history for this scan was chest, upper abdominal, right upper abdominal pain. So as you see, there's a PTBD. So the additional history is that this patient has a periampullary cancer, and they put a PTBD, after which they developed this pain.
It looks to me like there's like there's some biloma around along the edge of the liver, but there's also like all that thickened rind around it. And then you have this effusion. So sometimes you can get a bronchobiliary fistula. And then I don't know what that rind is. It's maybe just reactive.
Yeah. Anybody else has any thoughts?
Maybe did one of the side holes of the biliary drainage tube was slightly out, maybe?
Yeah, that was another thought which we gave. But as Aarti pointed out, like all the holes were like, there was none of the holes was outside. But as Aarti pointed, the one thing that struck me in this case, like there's this effusion, there are these bilomas, like that's, there is a smaller collection, as we can see, around the tube here. But this rind of thickening, so this, I thought that the diaphragm in this region is quite thickened and it looks inflamed. And it was perfectly normal before the like there's a prior preoperative pre-PTBD study. So I was wondering what could be like the cause of this. So I went back and checked the notes. So they mentioned that the PTBD was difficult. They couldn't enter the left side. So they had to go into the right side, and it was not very easy. So I discussed this case with our IR colleagues, and the first thing that they said when I showed this study was that this probably what has happened is that the catheter, the PTBD catheter, has gone through the diaphragm, and there's pleural injury, and all this is the pleural effusion should not be there post PTBD, and this was secondary to a pleural injury during the PTBD. So the PTBD was not low enough. So one of the pleural layers, it went through it and caused probably a bilio-pleural fistula. And then they, just to confirm this, they aspirated the pleural fluid, and it was positive for bilirubin. So yeah, I had not seen this before, and the one thing that like caught my eye was this thickening of the diaphragm, which I had not seen before. Like I've never seen diaphragmatic, like isolated diaphragmatic infection or inflammation, but then that history fit. So
I have a comment about that. If you show that case again, yeah, it does look really high, and generally wherever you have ribs, you have pleura. Right? Because the pleura goes all the way down there. So one of the rules they say is to try to stay below the 10th rib, because the pleura is like more sealed in the 10th through 12th ribs. So you can have the patient, you can place it when they're on exhalation. So the liver is not coming down as much and the pleura is not coming down as much. And you should try to go from below. So triangulate up and try to stay below the 10th rib. I've had cases where, we're draining like a liver abscess, like high at the dome, or a perisplenic abscess. And if we go like too high, we can definitely track that kind of stuff and you can even cause like an empyema. And so sometimes we tell them, like, in order to get to this location, we know that this is going to be a risk, like a high risk for a pleural fistula, basically, and an empyema. And if they start developing an effusion, we'd have a low threshold to place a drain. So it sounds like, I mean, it's very tricky for PTC. Like if it was tricky to begin with, like they're just trying to get into that little bile duct, right? And so probably they didn't have a lot of options, but yeah,
Right.
I haven't seen this thickened of a diaphragm. I've seen like the fistula, you know, where it goes into the lung base, but yeah, it looks like the diaphragm's really angry too.
And the first thing, like once I showed the case to the IR colleagues, I thought like effusion, I was not aware that I thought people like a small amount of effusion can be like post PTPD or post any procedure should be fine. But the moment they saw the pleural effusion, they said, no, this has gone through the pleura. And that's the lesson that I learned, that like if post PTPD, even this article, there's not much literature, but this article, they talk about 2 cases, and they said that if there is, say, pleural effusion post PTBD, that's one of the signs that there may have been some pleural injury. And they quote, I think, 0.5%. In 0.5% of the cases, care must be taken if there's pleural effusion post PTBD.
Yeah, I mean, this was a pretty big effusion too, right? Like it's not just like you can just get a reactive effusion if anything's going on in the liver, but this one is going halfway up his chest, you know, so.
Nelly, should I share the second case or do you want to go?
I can go. Is that okay if I go? And that'll give me a little bit
Sure.
of time to load the third case. Okay, great.
Sure.
Let me. So this is renal. Sorry, go ahead. What do you guys think about the renal kidney? So there's this lesion here. Right there, and it's let me see, we have any. Here's a coronal. Right there. So we only have a single phase, no prior. So like to me, when I look at this, it all looks kind of soft tissue-y, isodense, kind of heterogeneous density. And you know, definitely suspicious. So I think, and then so we got an MR subsequently, and I think MR is so helpful for renal lesion characterization because on MR we actually see that there's T1 hyperintensity within this, so there's a hemorrhagic component to it, and then on subtraction, really the lesion is not as big as you know it looks on CT. It's just this part, right? So this part is hemorrhagic, and then this little nodular component is the one that's enhancing. So for me, this was a great teaching case of how CT is really limited, and something that looks a lot larger, you know, you can have superimposed protein and blood, stuff like that, that makes that, and MR can be more accurate in really characterizing all of the different components, and, you know, really appreciate that this is more of a renal cystic lesion, probably a Bosniak 4, not a solid renal lesion, which is what it looks like on CT.
Nelly, I have a question for you. That part that ended up being hemorrhagic, what does it measure on this CT? Can you do that
on CT? Yeah, let me get the axial. So on the axial, probably this area here.
Yeah, that area.
So it is.
And Hounsfield
like
units
two.
too.
Oh, sorry. That makes sense. 80. Oh, okay. So it does, but it's post-con too, so I don't know
Yeah. It was
how
just
helpful that is. Yeah.
So I just wanted to bring up a paper that came out this year in AJR. It was a 12 institution study done by Matt Davenport, Stu Silverman, and the first author was Mike Corwin.
Yeah.
And it's a really helpful paper, I think, that they basically said if you have a homogeneous renal mass on portal venous phase CT that measures between 21 and 39 Hounsfield units, none of them turned out to be cancer. So anyway, yours didn't fall into this category because yours was 80. So it still had to get further workup, but they basically said, yeah, if you on portal venous phase CT, if it measures less than 40 Hounsfield units, they're highly likely to be benign.
Gotcha. That's great. And I think when we have just like a single phase or a non-con, it's the homogeneity and the heterogeneity that's more important than the actual like cutoff, right? Like you can,
right, and
if
also
it's
that
heterogeneous. Go ahead.
On the non-con, we use 70 as like to be highly likely to be a hemorrhagic cyst.
Mm-hmm. Yeah.
But also definitely the homogeneity. But you know, papillary cancers can be homogeneous as well. So I think it's a little tricky.
Yeah, but they're dense on non-con.
Yes.
I have a question for the group. I know like in most places that I've like worked, going back to ultrasound from cross section is usually like there are apprehensions about that. But like, for example, in this case, would you have suggested an ultrasound, or like it just adds another step and going for an MR right away would be the best step?
I mean, I think contrast enhanced ultrasound is as good as MR personally, but I think you get more characteristic features with MR, like T2, right? Like that can be really helpful, T1. So like I mean, personally, my personal choice is MR because, you know, I can really really narrow the diagnosis compared to ultrasound, which will just tell you if it's cystic or solid and enhancing.
Correct.
Aarti,
I feel like it's probably in the hands of the operator.
Yeah.
But that I usually rely on MR. And I also think this one, because it was like at the upper pole, it would be harder to see because, you know, you've got the diaphragm there. I think it would be a little tricky.
Gitanjali, what do you think?
Sorry, I was away for a little bit. I missed that discussion.
Okay. Do you like contrast enhanced ultrasound or MR for renal cystic evaluation or renal lesion evaluation?
We've not been doing much of contrast enhanced ultrasound, so my only experience is with MR, and I mean, I like it. I mean, obviously, we are so comfortable doing tissue characterization on MR, and I strongly believe that MR is really, really helpful in like doing that tissue characterization. You can clearly point out these are the cystic areas, these are the hemorrhagic areas. This is where your tumor gray with enhancement, that kind of tissue is present. So I prefer MR, but I have no experience with contrast enhanced ultrasound.
Yeah, our contrast enhanced ultrasound expert stopped coming to conference. David Fetzer.
Yeah, and like my question is more of like even general, like not necessarily contrast, because I'm not sure how many institutes do it that frequently. But even just like if you see like what is some lesion on CT, would we go directly to MR versus doing like a ultrasound if not already done?
I think MR is highly superior to just a plain ultrasound, and especially when you have these hemorrhagic masses that have like hemorrhage in one part and maybe a small enhancing nodule, and you might only see it on the subtraction images. I feel like we completely miss those on ultrasound. So
yeah,
whether those are clinically relevant masses is a different question because a lot of them are not very aggressive and they're starting to be more conservative about treating them. But okay, Amar, do you want to share your other case?
Sure. So my next case is more of an aunt Minnie, but I've not seen such a severe case of this pathology before. So anybody. So this patient, like I'll let you guys attempt, and then I can give you further history.
Is this all extensive extramedullary hematopoiesis?
That's correct.
Yeah, I think that too, especially with the chest findings too.
Yes,
like
those paraspinal masses, classic.
Yeah, I've seen like in this location, I've seen perirenal, but like the periportal one was quite interesting here. Like all this was also extramedullary hematopoiesis. I'm not sure what causes hematopoiesis in that region, but this was like one of the most florid cases of extramedullary hematopoiesis that I'd seen.
Yeah, that periportal stuff is really cool. I do know one thing, actually, when I was a medical student, I wrote a case report, or I did a case report for the American College of Family Practice or something. Anyway, I had a patient who we did a liver biopsy. They had like hepatomegaly, and we did a liver biopsy, and it was all extramedullary hematopoiesis. And what I learned was that you have these sort of like stem cells in your liver. So, you know, when somebody has florid extramedullary hematopoiesis, they in the liver and the spleen, they probably also have it there as well. And we usually just don't see the liver stuff. It might even just be hepatomegaly. So this was, I've never seen a case like this where it's so periportal. It's almost like squishing the portal veins there. But
when I first saw the case,
I don't know if you remember, Dr. Jambhekar had shared a case where he had shown an MR for a patient where there was all this periportal, say, soft tissue, and that was called, like, there was significant enough to cause biliary dilatation, and that all that turned out to be just a portal cavernoma and soft tissue related to that. So I just thought like this would be another differential for that kind of pathology. But in this case, there were other things going on. So like that doesn't fit here.
When I saw the case, one of the differential that came to my mind was Erdheim-Chester disease. Like, how did you guys get to extramedullary hematopoiesis? Like, so how do you differentiate those two? Because I mean, you get both. Oh, I guess because of the
chest findings in this one.
Yeah.
See the paraspinal one. So if you just had the renal stuff, then you would have to give both Erdheim-Chester and extramedullary, and then you can look at the bones, right? So like, especially if you're thinking extramedullary hematopoiesis, a lot of times there's a history of myelofibrosis or the bones look sclerotic. I think in Erdheim-Chester, don't they get like, they get something in their bones? I forgot. But it's not.
I think they get the
like the splenic
flask like deformity of the femur. But yeah, even I'm forgetting the pathophysiology behind it. And you get changes in the lung basis too, interstitial lung disease.
Yeah. For the classic image that they'll show in the boards for Erdheim-Chester is, I think, tibial periostitis at the proximal end of tibia, along with the perirenal soft tissue. So that's another distinguishing feature for. I have a case actually. I can share it next time.
I just noticed you're using Paxman.
Yes.
Amar?
Yeah, I'm currently. I don't like. Yeah, currently I'm not working. So these are the cases that I've saved before. I
that's
really
great.
Like this. It's great. It's great. Incidentally, this patient also had like a thrombus in their common iliac, external iliac vein on the left side. So yeah, that was my case.
I just looked it up. So Erdheim-Chester, you often get lung involvement that looks like Langerhans cell histiocytosis with predominantly cystic disease. You also get bilateral sclerosis of your metaphyses and diaphyses with cortical thickening, especially of your distal femurs and tibia. And then you can also get brain findings like orbital masses, retroorbital soft tissue, and then the perinephric stuff. So.
Okay, thanks for checking that. This is a companion case to Aarti's case from, I think, was it a couple weeks ago?
I have a theory, but I will let others. One, it looks retroperitoneal, and I'm thinking it's a sarcoma. And I think it might be an IVC leiomyosarcoma because I saw that interface with the IVC. There is a little bit of like dirty fat around it. So, but I think that's just edema. I don't think it's like a dedifferentiated liposarcoma.
Is it a left renal vein myosarcoma? Like, given the distribution.
This was a paraganglioma.
Oh.
I think there was vascular invasion. I think that both of you raised, but this came out to be a retroperitoneal paraganglioma. And I think, didn't you show a case of like paraganglioma by the duodenum.
Yes,
That
I
looked just
did.
like neuroendocrine tumor. Or
Yeah.
another case that looked exactly the same, but came out to be a neuroendocrine tumor. Anyways, yeah. So this was a biopsy proven and then subsequently resected, and it was a paraganglioma.
One interesting thing about your case is they had a bunch of calcs, which are
Mm.
not that common in paragangliomas.
Oh, is that right? Okay, I didn't know that.
That's one of the differentiation features between paraganglioma and adrenal cortical carcinoma. Adrenal cortical carcinoma tends to calcify more.
It also looked like an arterially enhancing malignancy, right? Even those metastases looked like there's from one of those arterially enhancing tumors.
Yeah, it makes sense in retrospect. It's just such a huge one and such an aggressive one. It's very malignant with all these mets.
The one thing that I've come to learn from these case conferences is like there's so much overlap. You
I know.
think you know what
This
it looks
makes-
like, and then you're like proven wrong the next day.
I have some cases. Does anyone else have some?
I have one.
Okay, go ahead. Swachchhanda.
Sure. So you can see my screen, right?
Yes.
Yes.
Okay, so this is a male in his 80s. So he has multiple past comorbidities like cardiac issues, atrial fibrillation, cardiomyopathy, and also patient has history of urinary bladder carcinoma in situ that was treated with intravesical BCG injection in the past. And patient was doing well until one day ago when patient started having nausea and vomiting. The vomiting was non-bilious and patient had epigastric abdominal pain. So at first the CT was done without contrast, and here we can see distended stomach, and we can see the duodenum first part, and suddenly the second, third, and fourth part of the duodenum is not distended. So there was some concern for obstruction at the duodenum. And here, this is the coronal view. So you can see this is obstruct. And suddenly there is narrowing in this portion, somewhat in the second part of the duodenum.
And I mean, it looks like right there, there's just soft tissue-y stuff. Like, I wonder if there's, yeah, yeah. And then posterior too. Right there. Yeah.
Yeah. What do you think? What's going on?
You said the patient has a history of malignancy?
Yeah, history of carcinoma in situ of the urinary bladder, but that was in the past, remote past. And yes. So after that, they got CT with contrast because of the finding that you picked up, this finding, some soft tissue density, and that is extending all the way inferiorly as well.
And causing hydro.
Yeah, so we can see hydronephrosis here. This is cyst, but yeah, definitely there is some hydro. So to better characterize, they did CT with contrast, and by this time patient had an NG tube, so the gastric distension is gone. But as we go down, so the duodenum, and suddenly there is non-distension of the second part of the duodenum, and here we have a lot of soft tissue stranding, and this thing is continuous with this faintly enhancing renal pelvis at the ureteropelvic junction area. So this thing is better seen here. So again, the second and third part of the duodenum and the soft tissue stranding. So somewhere here, I think we can see the enhancing UPJ.
So it's like a bad urothelial cancer that's extending beyond the ureter and obstructing the duodenum?
Yeah, that's the thing. And we can just extending inferiorly in the retroperitoneum along the ureter, I suppose. So when I read about it, I found it pretty rare. So there was a case report in 2020. It said gastric outlet obstruction due to upper tract urothelial cancer. That was the third case. I'm not sure, but yeah, it is pretty rare. I don't know how frequently you have seen this kind of cases.
I saw a case very similar to it, but it was from breast mets to the retroperitoneum, and exact presentation, gastric outlet obstruction, hydro, everything, and it was breast primary.
Yeah. So the upper tract urinary urothelial cancer itself is comparatively rare compared to bladder cancer, right? It accounts for like 5 to 10% of the case. And on top of that, upper tract urothelial cancer causing gastric outlet obstruction is extremely rare. So I thought it would be interesting to show the case. And one of the reasons why the cancer in upper urinary tract is more prone to cause direct invasion and extension is, unlike urinary bladder, which has thick walls, the ureter usually has relatively thinner walls, so there's more chance of direct invasion and extension. Yeah, that's my case.
Cool.
Great case.
One of the things about urothelial cancer, we know it's like a field defect, so it affects the kidneys and the bladder. And like you said, the bladder is much, much more common, but it's also more common if you have an upper tract tumor, you're more likely to get a bladder tumor eventually. But the opposite is not true. If you have a bladder tumor, it's still a low, much lower chance of getting an upper tract tumor. And my theory is that like the cells kind of like drip down from the ureter into the bladder. And so it puts that bladder at higher risk. But yeah, this is a pretty aggressive looking one.
On those lines,
but the drip down.
Yeah, go ahead. Sorry.
I mean, the drip down, they don't implant in the bladder wall. I would theorize that the incidence of TCC is higher, in the lower tract compared to upper tract, is because there's more stasis. Like you just have urinary stasis. So whatever carcinogen is being exposed is having a field effect.
Yeah.
That's what you're saying. That's what, yeah, that makes sense. Maybe those exposure is less.
I don't know that it's like, and I actually don't really think like, oh yeah, the cells actually are, dripping down and kind of spreading down there. But that's kind of how I remember it, is that exposure. Like, if you have upper tract disease, your whole field defect is like so bad that like you have a much higher incidence of getting bladder tumors. Whereas if a lot of people have bladder tumors and they don't end up developing upper tract disease. And I think it's probably like what you're saying, the bladder just has more stasis, so more inflammation, more chronic dysplasia.
I had a question on those lines. So at your institutes, do they do these studies, CT urograms to look for synchronous malignancies when they found, like they usually find a bladder tumor, and just to rule out, many times you've done these studies and most of them turn out to be negative. So what's the practice at your institution? Like everybody.
I think you have to do a CTU, right? Because even though the incidence is high, I think it's like up to like 7%, 5 to 7% upper tract synchronous lesion in patients with primary TCC in the bladder. So I think the AUA guidelines at least is to do a CTU to look for upper tract lesions.
Yeah, exactly. And Amar, there's like microscopic hematuria and there's gross hematuria. And usually microscopic hematuria has like a ton of different causes that don't necessarily involve malignancy. But in the US, regardless of what kind of hematuria you have, the AUI guidelines is to do both a CT urogram and a cystoscopy. Whereas in Europe, I believe they do like renal ultrasound. They do a lot less up front. But I think that's why we see a lot of negative CTUs, especially for like microscopic hematuria.
Yeah, that has been my experience. And probably in Canada, we follow similar guidelines. So because we also do a ton of these, and I've not seen like a positive case yet, although like, I can't boast of a significant experience, but yeah, most of them turn out to be negative.
Yeah. Gitanjali, do you want to go?
Yes. Okay, you all can see my screen.
Yes.
So history here is a 50-year-old female with jaundice, contrast enhanced CT. Going up to show that area again. So that was the axial. And that's the coronal from the arterial phase.
There's like an enhancing lesion in the left duct, like expanding the duct with Bill Dill.
Yes. So the cause for biliary obstruction is this intraluminal soft tissue, enhancing soft tissue at the hilum extending into the left duct. There's a little bit, I think, going in the right duct as well.
IPNB.
So, yes. Yes. So these are the MR images, shows it well. You have this tumor gray type soft tissue that's within the ducts. And the main thing was, I mean, we've shown this entity before, but this was a recent case that we saw. And I think there were two reports, there were two MRs that were done in a short span of time. Maybe the first MR didn't had good MRCP images and they really wanted for operative evaluation. And both the reports were like confident diagnosis of IPNB. It's like, so my thing was, I mean, there's so many differentials for intraductal lesions. I think it's still better to give a short list of differentials, or can we just confidently say that this is IPNB and nothing else? Because we've seen cases, remember we've shown cases of intraductal HCC. I have one case of intraductal lymphoma, but that was more along the distal CBD, which I've already shown in this conference a couple months ago. But yes, this one turned out to be IPNB. And it's good that this is an uncommon thing, but we all can make a definitive diagnosis of this on imaging. And again, this is also shown before, but a quick revision of what are some of the differentials for these intraluminal enhancing soft tissue intraluminal lesions. Common will be calculi and adenocarcinoma, and uncommon are IPNB. And this is more of a pathology differentiation. It could be intraductal tubulopapillary neoplasm. Very rarely you can get pseudotumors. Adenomas are also common, but they're just like benign polypoidal lesions within the bile ducts. And you can occasionally get metastasis and lymphoma. And I think one thing that needs to be added here is HCC, because we've seen two cases. I remember we had one case and Anu also showed one case of intraductal HCC. So for this case, the biopsy was intraductal papillary neoplasm with at least high-grade dysplasia. And a quick revision of this entity, that it's one of the uncommon subtypes of cholangio. You get three different types: intrahepatic mass forming and Klatskin are the two most varieties that we see. And rarely we can see something like this where you have intraductal soft tissue neoplasm. And this IPNB is an equivalent of IPMN in pancreas. So behave the same way. Same mucinous origin, and they are low-grade malignancies. And they secrete a large amount of mucin, and that's why you get this distension of the bile ducts. And on when they do ERCP, they can see the mucin outpouring from these at the ampulla in those cases.
But so was that just all mucin then, expanding the ducts?
I think in this case, it was both like biliary obstruction, but I bet there will be some degree of mucin too in that. I mean, I don't have the path that they described what was in the ducts distally.
Mm-hmm. Yeah. And then how do they treat that?
I think same, like they think of how they treat, because this is cancer, like, so the treatment will be same as it for Klatskin. So in this case, this was unresectable, but because it was going on both sides.
Both
so
ducts,
if it was localized to one side, they could have done like a partial hepatic resection with Roux-en-Y anastomosis, but this was going in both sides. So they said it's unresectable. And they're just treating her symptomatically with percutaneous hepatic drainage. And I'm not sure of any chemotherapy that she's on, so I'll check on that one. This was the case that we had shown last time, where we had this intraluminal soft tissue mass, and this was also a case of IPNB. Yeah.
Gitanjali, is there a way to distinguish these from hilar cholangio, like like on imaging, are there any clues towards that? Just on CT maybe?
Yeah, so hilar cholangio, the clad skin is more of, as the name suggests, periductal infiltrating. So there, what you'll get is thickening of the bile ducts with enhancement. We have seen cases where it's combined periductal infiltrating and mass forming together. So you get all those bile duct findings. And along with it, there's soft tissue that's growing in the liver. So we've seen those cases. And this one is you just get filling, soft tissue that's filling the bile ducts. But if you look at the wall of the bile ducts, there's really no thickening and enhancement.
Yeah, this one, Amar, you saw how it was like bulging the duct, like it looks like a polypoid lesion, right? And so that is pretty different than hilar, which is like sometimes you can't even see it. It's an infiltrative mass obstructing the bile ducts. I have a couple of comments. One, Gitanjali, my pathologist told me that they don't always have mucin in them, which is why the name doesn't have mucin in it. So as opposed to IPMNs of the pancreas, the IPNB, they took out the mucin part because they don't all produce mucin.
Yeah,
so that's one comment. And then the other is, like you said, they're lower grade. And so this one, for example, they don't even have, in that biopsy, they don't have a diagnosis of cancer. So the ones that I've seen, they actually can be, like, for example, that whole thing could just be high-grade dysplasia. It could be papillary frons with high-grade dysplasia. So the patient can do actually well. And we've had some where it was unresectable like this, but they did piecemeal resection inside, like intraluminally, and they were able to, like, debulk the tumor at least.
Yes, agree. For these tumors, these are usually low grade, and the biopsy just said high grade dysplasia. So high grade dysplasia is different from having an invasive adenocarcinoma, right? Yeah. So this one didn't show that. So probably that's why. But they were, like, I just read the notes. They were thinking of doing surgery, but then they said it's unresectable because it goes on both sides. So I'm not sure if they're planning to do that debulking surgery. That sounds like a reasonable thing for her.
And then regarding it's a beautiful case. Regarding your differential question, I think that this one, I like putting IPNB at the top for this one because it was like bulging and it looks papillary and kind of, like that kind of thing. But usually if it's not this kind of extreme, I'll give that versus like a cholangio, like a true intraductal cholangio. And it's a good question. I don't know about bringing up lymphoma and HCC because I feel like even though IPNB is rare, like those are even rarer. Like to just have lymphoma in the bile duct and not elsewhere would be weird. And then the HCC one, I think, is just such a rare thing that I'm not sure to bring it up.
Yeah. No, my other thing was lymphoma. I was not thinking of lymphoma in this case because lymphomas are, as like most of the time, they're very intensely restricting, and this wasn't restricting a whole lot. And then again, this was more brighter signal. I can show the images again. So this one is lymphoma is, I think it will be more iso to the liver. That would be the signal intensity of lymphoma. And if we see the diffusion, it's really not like lighting up like how lymphoma and all small round cell tumors light up. So lymphoma, but I was thinking of more like something benign, like can you put adenomas and papillomas or all those kind of stuff as differential for this, or we can straight away say that it's probably IPNB.
I mean, it's almost like just academic.
Yeah.
They'll have to take a biopsy.
Yes.
But I like it. I like being academic. So
that's all I have.
Okay, Amar, do you want to go?
Sure. So because we were discussing Erdheim Chester, I just pulled up that case. So this was a pathologic proven case of Erdheim Chester with that rind of soft tissue. And in fact, this patient had extensive disease elsewhere. Unfortunately, the skeletal survey does not include the tibia, but this patient also had lesions elsewhere. So extensive lytic sclerotic lesions throughout the skeleton, better seen on the CT, but this patient had that characteristic periostitis involving the upper end of tibia. So just thought of sharing this case.
Cool, thank you. Look at that, Pax been able to pull up a case immediately.
You know, Amar's like a pro at Paxton. He'll have to teach me some tricks, like combining studies in one file.
Yes, Amar. So, Amar, I also had a question on Paxbin. So, is it easy to organize, like you have your different folders?
Sure. Yeah, so you can give, say, you can tag them. So for example, I have all body cases together, all GU cases together. You can give multiple tags to them. So for example, if you're collecting hepatobiliary cases, so you can give them a tag called hepatobiliary. Or it's very easy. And the best part is you can try it out. I think 10 or 20 cases are free.
Yeah.
So like you don't need any subscription for that. So so far my experience has been very good.
But you can have different folders that you can, like, as you're saying, like one folder for hepatobiliary cases, one folder for GU cases, and then the cases will be in those. And you can search them by diagnosis, and you can just search them by the folder in which they are.
Anything like, yeah, we can, like, I can show you, like I can do a short session later, maybe at some time for the group, that I can like do a tutorial. How do I like have done? And because like I don't know if everybody would be interested. I can show it right away, but we can do it sometime later maybe.
Because this so far seems to be the most efficient way of creating your teaching files and like pulling up cases in no time whenever you need them.
Yeah.
Yeah, I think so. Yeah.
Okay,
Yeah,
so
the alternative
actually,
is you can have it
think,
like on your computer and like Osirix or something, but this is easy. Like if you want to have anywhere, like it's on the cloud, so you can pull it up anywhere.
no, it's very cool. There's also a companion case that wants to be shown, I believe, by Kedar. So he can go, and then Nelly has a couple more.
Yeah, thanks. We had written up a case on Erdheim Chester, so I just wanted to show a couple of images. I couldn't find the case, but can you guys see my screen?
Yes, it's Erdheim Chester Day.
Yeah, so these are the changes, retroorbital soft tissues, and then this is the soft tissue in the retroperitoneum peripancreatic region. And the thing that Amar couldn't show earlier, the tibial metaphyseal sclerotic lesions, metadiaphyseal. I think the perinephric soft tissue. So this was like from 2011 or 2012. So that's it.
Cool. I still have my Wikipedia up about it, and basically I was looking to see the treatment, and it basically says it's very difficult to treat. Steroids, radiation, and chemotherapy are basically ineffective. Some stabilize and some just progress. And it was first described in 1930 by Jacob Erdheim and William Chester, American and Austrian pathologists. Okay, Nelly, want to go?
Yeah. Okay. GI case, obviously. So the patient has a history of gastric bypass, came in with stroke. And then when they did a TEE to look for sort of source of stroke, they had resistance in the esophagus, like mid-esophagus. So they got an esophagogram. So when to me, when I was looking at this esophagram, it looked a little funny. Like we don't have any priors. The sort of the distal segment. So this is the bypass changes. The distal segment seems to be displaced to me a little bit to the right. There's no focal narrowing, but so I'm like, oh, I didn't know what was causing it, but I like sort of saw it on multiple planes. So then, any thoughts from you guys?
Rhina appears a bit splayed. Is it because of left atrial hypertrophy, enlargement?
Yeah, that's what I usually think of with rightward deviation.
Yeah. So yes, the patient subsequently had a CT, and that's what it was. The atrium is significantly enlarged, and it's displacing the esophagus. So I saw this article, which was I thought kind of neat. See if I can make this bigger. So you can have a push or a pulled esophagus, and depending on what part of it is being kind of stretched. So in that the A, this one, it says if you have an extrinsic compression, then you sort of get deviation of the medial segment. In contrast, when there is retraction from scarring or whatnot, then you have like this wider length. So I didn't appreciate that, but so here's some. The caliber seemed intact and maintained, so maybe it wasn't a significant push to cause the caliber narrowing.
It's interesting that caused them to abort their echo or be concerned about the esophagus, because you'd think they would see it being pushed by the and then they would just like put their ultrasound on it and see that it was the heart.
Oh, I see what you're saying. Yeah. I think they felt a lot of resistance, and I don't know. They didn't see that the resistance was coming from the atrium.
Okay, I'm going to share a couple of quick ones. Is that cool?
Go for it.
Okay, so this is the first one. You can see that the colon looks distended. There is a clue.
Yeah, gallstone.
There's like a there's like a, what, oh my gosh. Is it a mass or is it an abscess?
It looks like a face kind of, but yes, it's a perforated gallbladder. It has perforated into the liver with this contained biloma in the liver. Then there's a couple of other findings. One of them is on this image.
The gallstone ileus. Yeah, go ahead.
In the rectum too.
Yeah, exactly. So there's one gallstone down here that actually got caught up at this area. The person ended up going for a colectomy, and this was just an ischemic portion of the colon. So I don't know if these are like true and unrelated, because I'm not really sure this gallstone caused like the colon to suddenly become ischemic and strictured here. But anyway, so he had ischemic colon with this gallstone stuck there, had another gallstone here at this anastomosis of the gastric bypass. This was a gastric bypass. So anyway, and then you can see kind of basically that the gallbladder is inseparable from the duodenum lumen here. And so basically there's a fistula that once they did the cholecystectomy, they could see that it was like completely adhered, and these were like open to each other. And so these gallstones have just been passing from this gallbladder through the duodenal fistula, one of them in the small bowel and then one in the colon.
That's amazing.
Yeah, it's pretty crazy. And bowel obstruction. So I don't know. I don't know that the gallstone itself, I know it can cause obstructions. It usually, when you have gallstone ileus, it usually gets stuck at the ileocecal valve and the terminal ileum, and it usually causes a small bowel obstruction. I feel like this one could have passed here. I'm not really convinced that it caused the stricture and the ischemia of the colon. So maybe true and unrelated, but pretty cool. This is another quick one. Any thoughts?
Fishbone.
Yes.
Wait, and then we also saw like the barbecue grill thing too before.
They said that was common in Arkansas. So this one is a fishbone. We actually don't know what kind of bone it is. It could be a fishbone or a chicken bone. They removed it endoscopically, and the path just says bone fragment. And you can see it's actually causing severe gastritis here as well. And then this was just random. It was like an extruded endoscopy clip. So it's just kind of like randomly unrelated to it.
After seeing all these cases, when I see a fish, I get really scared.
I know.
I'm so scared to eat
Recently,
it now.
somebody tried to get me to eat one that had like tiny bones in it. And I was like, this can lacerate your intestines. And they're like, why are you saying this? I'm like, because I've seen it. But I mean, I think the small ones, I don't think they do them, but like this one's a huge one, right? So yeah, beware the fishbone. And then actually there's an interesting debate we've been having recently about these endoscopy clips because, for example, for rectal cancers, if they place a clip, it basically makes our rectal MRIs like impossible to read because there's so much artifact. But also most endoscopy clips are not considered to be MRI safe because they can heat up and break off and cause GI bleeding. So recently we were doing some research and there's like a Boston Scientific clip. This is not an ad for Boston Scientific, but there's one that's MRI compatible and MRI safe that they're starting to use more at our institution, but it still creates a lot of artifact. So just beware. The surgeons now are trying to be more careful about placing clips before they send their patients for rectal MR.
Quick question. So why is the clip outside the lumen or outside the wall?
Oh, I think it eroded. I think it's like extruded through.
Oh, okay.
Yeah, not
Is that common and no significant?
It's not common. But this patient was like asymptomatic from that. Okay, and I'm just going to show you one more cute one. This patient came with a history of a vaginal septum. And I thought it was really cool. You could actually see it here.
Oh, wow.
And so it almost looks like two vaginas low down, and then up top, it's like one. It becomes one and it's fluid filled. So it's like a partial vaginal septum of the lower vagina. And these are most commonly are associated with also Mullerian abnormalities. And so what they wanted to know was what was going on with the uterus. But in this case, this patient did not have a uterine abnormality. They have a nice contour, so they don't have a bicornuate uterus. It's nicely fused. And this even didn't even make the criteria for like there's no septation here. There's only like a 6 millimeter divot between the two horns. And so for a septum, it should be greater than a centimeter. And then the other thing I learned was that, and this now makes sense to me, but I didn't realize this, that the Mullerian, like basically the vagina is two tubes that then fuse together. So the septum is basically when the two tubes do not fuse. And same thing with the uterine horns. They're two separate horns that have to fuse properly. So it's pretty amazing that it even, happens properly most of the time. But anyway, this was a case of a vaginal septum. And a couple of other things about that is that you can have transverse vaginal septa like these, and they can be incomplete or complete, high, middle, and low. And you can have vertical ones. And the vertical ones, sometimes they diagnose them, immediately, but maybe they have difficulty with menstruation, difficulty putting in a tampon, etc. And then you might find this vertical septum, and basically they just remove the septum and they do like a septoplasty, and then that's how they treat that. So ours looked like a sort of partial vertical septum.
Cool case.
Yeah, that's cool. Okay, I'll save my other ones for next week, and I'll see you guys later.
Bye, everyone.